My name is Kaylee Vitek, and I will be operating the Zoom logistics of this webinar and introducing today's speakers. When I'm not providing tech support for PQI, I'm the project manager for the Massachusetts State Perinatal Quality Collaborative. There are a couple housekeeping items before I make our introductions for today. This webinar is being recorded and will be posted for free on the PQI website. There will be time for Q&A at the end of the presentations. Please type any questions you have into the chat and we will address them. If you experience any technical issues, please send me a private message. Now to introduce our speakers. Karen L. Florio, DO, MPH, is a maternal-fetal medicine specialist board certified in obstetrics, gynecology, and maternal-fetal medicine. From 2014 to 2022, she served as the director of the Heart Disease and Pregnancy Clinic at St. Luke's of University of Missouri, Kansas City, a program she developed as a joint collaboration between the obstetrics department and the prestigious Mid-America Heart Institute. She moved to the University of Missouri in Columbia in 2023, where she serves as the vice chair for patient safety and quality. Outside of her clinical duties, she is currently the chair of the Missouri Perinatal Mortality Board and is the maternal section lead for the State of Missouri Perinatal Quality Collaborative. Our second speaker is Megan O'Brien, RN, BSN, she, her, who is a bachelor's prepared registered nurse, spending nearly all of her 15-year career in the field of women's health, specializing in reproductive endocrinology, family planning, and high-risk pregnancy care. Megan currently works at Boston Medical Center, a large academic safety net teaching hospital, as the clinical nurse program manager for BMC's remote blood pressure monitoring program under the hospital's Health Equity Accelerator, which is a program she co-created during the initial surge of the COVID-19 pandemic as a way to keep both pregnant and postpartum patients safe. This program has gained national attention and was recently awarded an Innovation Award from the U.S. Department of Health and Human Services. She has a deep passion for continuing to improve the lives of birthing people and reducing racial disparities. And now I will turn it over to Dr. Deborah Bingham, who is the founder and CEO of the Institute for Perinatal Quality Improvement. Thank you all for being here and enjoy today's webinar.
And welcome everyone to today's webinar. We love being able to offer these innovative webinars for all of you and to share them with the country and our webinar library. I have a few updates from PQI that I'm going to go over. First, our mission. PQI was formed in 2016 to expand the use of improvement science to eliminate preventable perinatal morbidity and mortality and end perinatal racial and ethnic inequities. The reason we've formed is because we've got problems with infant mortality rates in the United States, and you can see there's wide range of variation of these rates across the country. And even within states like Massachusetts, where I live and work, is the rates that are lower, there will be sections of that state where they are higher than they should be, these inequities in outcomes. We also have pregnancy-related mortality ratios by race ethnicity, and we see that non-Hispanic Native Hawaiian or Pacific Islander and non-Hispanic Black women and non-Hispanic American Indian or Alaskan Native are suffering a much disproportionate amount of these deaths occur within these populations. And that's why we are working so hard to end these disparities. We also are concerned about high rates of morbidity, especially for maternal morbidity rates. And these in 2014, they had increased by 200%. From 1993. So just again, a little brief update from PQI, let you know what we're working on at the moment. Every decision we make is focused in on meeting the mission of the organization. One of the things that is a tenet of our work is that conversation is where change begins, and we all have the power to change the conversation. And thank you for joining our conversation today. So we developed the Speak Up acronym and mnemonic And this is posted on our website, and we're in the process of, we have a Speak Up action and learning pathway, which is that first you become a Speak Up champion, then you become a Speak Up ambassador, and then some people will go on to become Speak Up faculty. And we are launching our first faculty course this fall, and it's very exciting. So we hope you join us as Speak Up champions. Our goal is that all perinatal health professionals in the United States become Speak Up champions, that we would have a shared mental model around how to discuss and understand these inequities and racism in our country. We have our next national Speak Up Champion course, virtual live. It's spread between 2 different days, the 1st of November and the 10th of November, from 8:30 a.m. to 12:30 a.m. on both dates. And we would love to have you join us. There's CNE and CME for those events, and that registration is live. And early bird registration ends very soon. We have over 1,500 Speak Up champions. This was as of June 2022, and now we have over 1,500 Speak Up champions in the United States. You can see they're spread quite a few spread all over. So again, we have our Speak Up National course, which is open to any perinatal health professionals, and that's on November 3rd and 10th. That's a prerequisite to attending the ambassador course. And we have an ambassador course, a national ambassador course on December 1st. So hopefully we see you at both of those events. And again, early bird registration ends on the 22nd for the champion course, and early bird ends on the October 20th for the ambassador course. We also have CNE and modules, why everyone must speak up, pledging to speak up, and how to speak up against racism and perinatal health care. We also have a free anti-racism challenge. It's 28 days. You can join us for a week or the entire 28 days. We'll start on February 1st, 2024. It is free. Everyone is welcome to join us. It includes reflection, learning, and action activities. We have some hospitals that have gotten an entire hospital groups together and done this as a hospital team, perinatal teams. And the registration is open. You register and you will get an email every day that reminds you of the learning activities with all the links. Again, it starts on February 1st, 2024, but register now so that you can be prepared for that. The other big thing we're working on is reducing overuse or ending overuse of C-sections. And one of the ways we're doing that is around intermittent auscultation. We feel very strongly that women in the United States have the right to be able to have freedom of movement and have options in labor. And we have a simulation-based course where clinicians can learn how to perform intermittent auscultation, and so that they feel they have the skills and it can be performed in a safe manner. We have actually, as of June of 22, again, we have thousands of people who have gone through our course. And so I would love to have you join us by taking this education. In addition to our mission is expanding quality improvement skills and knowledge. And so we offer Quality Improvement Essentials National Conference. And we'd love to have you join at one of our future conferences. And our dates, we have not announced the dates yet for 2024. Again, the PQI Innovation Webinar Series, which you have joined with us today, they are recorded and they are posted both in our website library and also on YouTube. And you can subscribe to our Perinatal QI YouTube channel and be able to view these webinars. And we will have this webinar posted a few days after the event today, and we'll announce that to you and send you that link once that is posted. Our next webinar, the last one for 2023, will be on promoting neonatal equity and justice through the Neonatal Justice Collaborative, which is a new organization that was formed for the United States. We're very excited to have the Dr. Anani and Dr. Carbonen be speakers and help us learn more about their work in neonatal justice. Please also consider becoming a member of PQI. Paid members help us meet our mission, and we'd love to have you join us in that regard. And just keep in mind, QI saves lives. And if you have any questions or suggestions for PQI, you can email us. You can also submit contact forms through our website, and we hope you join us. Now I'm going to turn the time over to Dr. Karen Florio, and she's going to give her part of the presentation. So thank you so much.
Great. Thank you so much for that introduction, Callie. And thank you again for inviting me here. It's such an honor to be here speaking to you all. So we're going to get through this really quickly because it's really hard to get through postpartum hypertension monitoring in 20 minutes, but we're going to try. So we're going to talk a little bit about physiology and how postpartum hypertension might be a little bit different physiologically than what we see and are used to in antepartum and intrapartum. We're going to talk about disparities in outcome, the validity of home blood pressure monitoring, which is what we're really talking about today, appropriate selection, patient selection for home blood pressure monitoring and potential barriers that we face. And then quickly an overview of what we're doing here with our Perinatal Quality Collaborative when it comes to home blood pressure monitoring. So quickly, we're going to go through all this. So just a quick overview. When I'm talking to my patients about hypertensive disorders of pregnancy, right? We know that they are placental disorders. And what happens is that there is shallow implantation of the trophoblastic cells within the spiral arteries, right? So what you can see here is what's supposed to happen where the cytotrophoblasts come in, invade the tunica media or the muscular wall of the vessels and create these big flaccid pools of blood that the placenta can bathe in, right? But what happens in any type of placental disorder, growth restriction, abruption, stillbirth, some literature to suggest preterm labor, and then obviously hypertensive disorders, is we have that shallow implantation, and you can see that the spiral arteries maintain that muscular wall, which causes them to spasm. So we always keep that in mind when we're talking about hypertensive disorders, because if you have a history of a hypertensive disorder, you know, it's kind of like, which straw are you going to draw next time in your next pregnancy? Is it going to be the growth restriction straw? Is it going to be the preeclampsia straw? Because all of these diseases come from shallow implantation of the placenta. And so we know that there are certain risk factors for hypertensive disorders of pregnancy. They can be acquired risk factors or environmental, genetic. It's funny, I teach residents, right? And they always ask me, why did you ask if that dad was a growth restricted baby? Or why did you ask if he was a preeclamptic baby? Because we know that that runs in families, right? There's an immune component. And what happens, you can see here, is we have impaired trophoblastic implantation, as we talked about. You can have uteroplacental malperfusion or decreased perfusion, which leads to placental hypoxia, and a whole wide variety of different immunologic and hormonal responses. One of the things that you're seeing a lot in the news now, and we're going to talk about that they've been doing extensively in Europe, is this new imbalance between SFLT and other angiogenic factors such as VEGF and placental growth factor. And then it leads to, as we know, growth restricted babies, liver or hepatic dysfunction, proteinuria. I always wondered why we chose the kidneys as the definitive marker for the diagnosis of preeclampsia, because we know that preeclampsia or hypertensive disorders are an equal opportunity destroyer of all organs. And so why did we choose the kidney, right? For me, I am a preeclampsia survivor. It was my brain and my liver, but I never spilled a drop of protein. And so I'm really encouraged that our governing bodies are jumping on board with this and not just labeling the kidney as the organ for diagnosis. We're looking at all organs now. And so you can see there are a multitude of risk factors when it comes to having preeclampsia or hypertensive disorders. We know that I remember back, I'm going to date myself now, in 2007 when I started residency, we were told that if you had a history of prior preeclampsia, you're not going to get it again. But we know that that's actually not true. You have a 7-fold risk if you have a history of it, which is why I have one child, by the way. I like to not be sick and be hospitalized. So, and then you have a multitude of other risk factors, right? So don't want to spend too much time on antepartum and intrapartum preeclampsia. We're really kind of focusing on home blood pressure monitoring and postpartum monitoring. And so there's this really great article. Actually, this person here was the one who took care of me when I was preeclamptic, and I'm so grateful to her for that. So Elise Hofsprung and Arun J. Balan put out this really great review article on the differences of postpartum preeclampsia and antepartum preeclampsia. We know that the incidence of postpartum preeclampsia can be up to a third. Sometimes we don't see it until at all until postpartum. And they're really arguing that this could be a totally different beast altogether. There are similar risk factors, but there are also different risk factors. And we'll talk about this in the next slide. And then we know through basic science studies and epidemiologic studies that SFLT, there's an imbalance between SFLT, which is anti-angiogenic, and placental growth factor, or VEGF, which are angiogenic. And when you get that imbalance where you have too much SFLT and lower VEGF, or placental growth factor, you're at higher risk for things like preeclampsia and actually cardiomyopathies. There's a lot of overlap between them. And so we know that if you look at antepartum preeclampsia versus postpartum, we know that there are higher levels of SFLT in that postpartum population. And they also might have a different immune response altogether. What I find really interesting in this review article was that there are certain risk factors that we see for postpartum preeclampsia that we don't see for antepartum, including having a cesarean delivery, which potentially could be due to all the fluid those patients receive. And then we see the clinical manifestations can be very different. How many times have we had to call cardiology or somebody else to help us because we just can't get their hypertension under control in the postpartum timeframe? And we tend to see a lot more neurologic symptoms in the postpartum period. I can tell you that for me, that's when I got PRES, right, in the postpartum timeframe, because I had these really bad headaches and when my liver enzymes really elevated. So just things to think about when you're thinking about the physiology of preeclampsia. I'm trying to get through this really quickly, guys. So I'm going to minimize our faces because we're in the way. So how do we screen for preeclampsia in the United States? Well, in the United States, we use the United States Preventative Task Force guidelines, which is really just demographic factors. And so if you have any of these factors, we recommend that you start a baby aspirin. However, we do things very differently in the United Kingdom, or I should say in Europe, right? Because it was a multitude of countries. For years, they've been screening for preeclampsia using biomarkers and then targeting those patients for aspirin use, okay? And so what they do is they look at history, kind of like what we do with the United States Preventive Task Force, mean arterial blood pressure, uterine artery pulsatility index, and then biomarkers. And what they found is that with this type of screening modality, their detection rate of preeclampsia at less than 34 weeks is 90%. And with that, when they target these populations to give them aspirin, they've been able to prevent 89% of preeclampsia. So then the question becomes, why don't we do that in the United States? And the quick and dirty answer is it's all because of money. So this is a really good, because we don't have universal health care, right? So it costs money. And so this is a really good study by Malampati and Grobman that looked at a cost analysis of having no aspirin whatsoever, what they do in Europe, what we do in the United States, and then universal aspirin. And again, you can see that there is a multi-million-dollar difference between what we do in the United States and what they do in Europe. So we know that hypertensive disorders of pregnancy can cause significant morbidity and even mortality in this country, both in the antepartum and postpartum period, which you can see here. We know that the cardiovascular effects are significant, both during pregnancy and what we are all finding out now for those postpartum timeframe and overall quality of life for people. So we know that the short-term morbidity for cardiovascular disease is still prevalent. So we know that people that have preeclampsia severe disease or eclampsia have a much higher cardiovascular risk associated with hospital delivery during that hospital delivery than those who don't have hypertensive disorders of pregnancy. And that risk for any type of cardiovascular disease, which I'm going to show you in subsequent slides, is significantly higher. And this is usually due to arrhythmias and heart failure. And so this slide always, I've had this slide for a long time. This slide always really cuts to the core of me, and why I chose to have one child is because my risk of having cardiovascular disease in the future, because my overall quality of life is important, right? I'm in my 40s now and I have to start thinking about these things. But my risk of having cardiovascular disease, because I had early onset preeclampsia with severe features, is equal to that of somebody who smokes or is obese. I mean, sit on that for a second, right? And these things can occur as early as 1 year postpartum, which is why we're going to talk about early monitoring. And I always tell people 1 + 1 actually equals 2, again, which is why I have one child. Every hit to the heart with preeclampsia increases your risk for cardiovascular disease further in the future, right? And I can exercise and eat organic food and do all the things that I'm supposed to do, but I can still never get my risk back down to baseline. And so this is a really good meta-analysis that looked at this exact thing. What is your cardiovascular risk in the future because you've had an episode of preeclampsia? And so the way to read a forest plot is this side is positive, this side is negative, meaning this is protective, this increases your risk. And so the size of the diamond equals the weight of that study. And the one I want you to pay attention to is down here. So your risk of heart failure with preeclampsia is higher. Your risk of having a stroke is higher. Your risk of having coronary artery disease because of preeclampsia is higher. Coronary artery related death is higher. That one's always gives me chills. Any kind of cardiovascular related death is higher. And this is the one why I actually am on a statin now and on diabetic meds, is because your risk for heart failure, stroke, and coronary artery disease in that 1 year postpartum. I can tell you, I'm a really healthy person. I was a college athlete. I used to do Ironmans, and my A1C, my first year out of preeclampsia, was 5.8. Right? So it does happen to you within that year, and why I encourage you to be following these people in that 1 year postpartum. So we've talked about the risks, right? We talked about the pathophysiology. Let's talk about disparities in hypertension. I live in Missouri. I was just telling my colleagues earlier, Missouri is a fantastic place. You guys have no idea. It's so beautiful. The people are incredibly nice, but I'm not going to tell you that because I don't want you to move here and increase our cost of living. But we do have our own problems, right? You can see that we have significant disparities in outcome for hypertensive disorders of pregnancy. I work at the Department of Health and Senior Services and for the Missouri Hospital Association, and we consistently see significant disparities in our outcomes for hypertensive disorders, for mortality, you name it, we have it. And so if you look at, we all know this data really well. If you look at people who are native born to the United States and those who immigrate here and have babies, if you are of African descent, you have outcomes equal to those of white American residents. But as time goes by and those generations are born here, those disparities and those outcomes look very similar to Black women born in the United States who are native to the United States, meaning there is something inherent about our system, I think we all know what it is, discrimination and years of racism, that cause these disparities. And that's what this data shows you. And so if you look at that again, we know that outcomes are worse for Black Americans that are born and are residents of this country. So if we look at prevention, right? What about if we gave everybody aspirin, right? Could we decrease these disparities? And the answer is no, right? So if you look at, again, this is preventative, this is an increased risk. What you see here, the only people that receive aspirin that it actually works for are whites in that low risk aspirin group. Again, there's something inherent in our system, structural racism and years of disparities that we have imposed on marginalized people that are leading to these outcomes. So if you look again, Low dose aspirin tends to work in white population, but doesn't tend to work in our other populations. So I always find this very interesting, and kind of to drive the point home is that I want you to pay attention to these two boxes up here. This is a really great central illustration from a Jack article on preeclampsia. Essentially what we're summing up here, and you could take a screenshot of this, is that if you take a white, low-income American, her outcomes are going to be better than a high-income, highly educated Black American. And that's essentially what it's showing here, is mortality, peripartum cardiomyopathy, all the things that go along with preeclampsia are not reduced for the Black population, again, looking at disparities. And if you look at an ecologic model, again, driving the point home on how this is happening, we know that slavery and Jim Crow and redlining, all of those things have led to the years of disparities that we're seeing now. And we're kind of scratching our heads like, why are Black women dying at a higher rate? Well, it's because of structural and social determinants of health. And I would argue that this is not a complete ecologic model because we are significantly ignoring the Native population, which if you look at the numbers in general, we know that Black birthing people are dying at higher rates. But the one that has the steepest incline, the one that is dying at the fastest rate are the Natives. And again, due to structural and social racism. So I just want to briefly look at the Missouri data because this is what I know very intimately. We know that on our PAMR board, we disaggregate this by race. And if you look here at any kind of hypertensive disorder of pregnancy, we know that our Black birthing moms have significantly worse outcomes. Other disparities that we look at in Missouri, and this is probably across the board, right? No state is perfect. Even in California, where they were able to reduce maternal mortality by 55%, they were only able to reduce maternal mortality for Black birthing moms by 50. So every state has this problem, and we all need to be paying attention to it. So we know that 1 in 4 mothers in Missouri don't start prenatal care until after the first trimester. Again, worse for our Black birthing moms. Higher rates of obesity in our birthing population, but again, worse for Black mothers. And it all comes down to food insecurity, right? It doesn't have to do with lifestyle. It has to do with the fact that there's no grocery stores with fresh fruits and vegetables. And the cost of fresh fruits and vegetables are incredibly high right now. I made myself a kale salad yesterday and I thought to myself, I should just go to Wendy's, right? But I didn't because of my risk for preeclampsia adverse outcomes. We know that severe maternal morbidity is worse for our Black birthing moms, and things like paid maternity leave. Less Black birthing moms have less paid access to paid maternity leave than white birthing moms. And that makes a difference, right? Because they're not paying attention to their signs and symptoms and they're not following up, and therefore they're having worse outcomes, right? Again, just driving the fact home that Missouri is great, but again, don't come here and raise our cost of living. But you can see that we have a significant problem with disparities in this country, and it's specifically in our state. And so if you look at the reasons for inequity, this is all the things I've been talking about, right? If you take it from an individual level, I love ecologic models. I don't know if you guys do, because it takes it from the individual level all the way up to the national level. And you can see all the things that we're talking about from an individual level. When we're on the PAMR board, we actually look at opportunities for intervention. And people get a little bit frustrated because we say, oh, there's opportunity for intervention on the provider side. It's not blaming the provider. It's just recognizing that there are opportunities where we could be better, right? So on the patient side, we think of things like health literacy. We are not educating our youth today on health literacy. When you think about the family, there's lots of family dynamics. We all have family dynamics, right? That can impact our health outcomes. At the national level, at the state level, expansion and extension of Medicaid, right? We know that in Missouri, we have voted to extend and expand Medicaid, but we have still not implemented it. And because of that, we are seeing that Medicaid covered patients have a tenfold higher rate of mortality. So how do we reduce these disparities? Essentially what this data is showing you, and I want to be quick here and I don't want to go into significant detail, but this is a really great study on how do home blood pressure monitors compare to in-office monitoring during pregnancy. So it's divided by systolic blood pressures in early trimester, mid-trimester, and then late. And essentially what you're seeing is there's no difference, meaning you can actually monitor them at home and have the same outcome as you would antepartum. Or in the office. So I would encourage you, when you have people who don't have access to transportation, when they have significant barriers to making it to their office appointments, such as lack of childcare, the Medicaid van doesn't get there on time, you can actually monitor them at home, and you don't have to bring them into the hospital or into the office, which is 2 hours away, right? Again, looking at this in just an overall, are their blood pressure similar? The answer is yes. This is a Bland-Altman chart. And what a Bland-Altman chart does is it compares two modalities. So it would compare like a non-invasive cardiac monitor to an echo, or it could compare, in our cases, the ambulatory blood pressures like you would have in the office to those as outpatient. And what you want them to be is within this gray range. And you can see, again, I'm just giving you more validation that you can do this at home and be rest assured that they are equal. Now, you should validate the blood pressure monitor or the cuff that you give them in the office to make sure that they're equal. For those of you who have not done your MOCs yet, for OBGYN, one of the MOCs is the BUMP2 trial. So the BUMP2 trial, again, is Europeans do everything better. They do food better. They do wine better. They do healthcare better. And so what we found is that in the BUMP1 and BUMP2 trials, they looked at equivalency of, again, home blood pressure monitoring in normal population and then in high-risk population. And that's what BUMP2 is. And what they found is that monitoring doesn't necessarily lead to an earlier diagnosis of preeclampsia or better outcomes, but what we want to know, is it equivalent? And the answer is yes. So we'll move on from that. Lots of fun data. I can send you guys my slides. Okay, so we talked about antepartum. No, it works antepartum. You do not have to bring them in every week to monitor their blood pressure. You can do it at home. What about postpartum? The answer is yes. And Megan's going to talk about this after me, so I'm not going to belabor that point. But let's get down to, are patients satisfied with this? Are they compliant, and do they like it? And so this study looked at an app that monitored your blood pressure for 7 days. So were patients compliant? The answer is yes. Did they find it difficult to use? The answer is no. Did they feel like the software on the phone was helpful? The answer is yes. And did they find the way that they did it in red, green, and yellow, like, stop signs, because everybody knows what a stoplight is, right? Was that helpful? And the answer was yes. And so just to sum up now, because I want to get to Megan, because I know she's got a lot of really useful and great information, is how do we do this in Missouri? We partnered with the Preeclampsia Foundation, and we got a few grants to purchase blood pressure kits to give to patients in Missouri. And the goal of this was to reduce disparities. So our focus was on equity and decreasing disparities. And we distributed over 7,000 cuffs. And we made sure that we didn't just do them in hospitals. They had to be at community-based centers, churches, and things like that. And we're running the data on that now. And what we've done and what we do really well in Missouri is that we join hands with the Department of Health and Senior Services, the Missouri Hospital Association, and our Perinatal Quality Collaborative. And we make sure that we work together and nobody's working in silos. And that's how we were successful in getting these grants and distributing over 7,000 postpartum blood pressure cuffs to people. So I don't want to belabor that point. I want to introduce you to my colleague now, Megan, who's going to talk to you about this really cool project that she was nationally recognized for.
Thank you, Karen. Thanks so much to the PQI team for having me here today. And thank you guys for being here as well. So I am just going to screen share here. It's going. So I am going to talk about how we implemented our remote blood pressure program in a hospital system. So I work for Boston Medical Center, and over the last 3 years, we've worked really hard, really pushed by the COVID-19 pandemic to get blood pressure cuffs into the hands of patients that we know are at high risk for preeclampsia, prenatally and postpartum. So just a little bit about Boston Medical Center. By the numbers, we deliver about 3,000 babies annually. We have a network of about 13 community health centers and about 3 locations within the hospital in Boston, Massachusetts. We have our own accountable care organization. So we have a lot of ties to the insurance piece of this. And so it made, a lot of sense for us to really delve into a couple of these initiatives. And so this blood pressure program really took speed when we were able to get a little bit of grant funding. As Karen had mentioned, grant funding has really helped us get our program off the ground. We also have really started to delve into health equity, why we're seeing these different rates of outcomes between patients. And so we were really able to capture a big audience and to help elevate our message and why this was important and why we needed to start to do things a little different. Here's kind of a quick overview of the 5 things that we really focused on when we started this program. We were looking at financial stability, the time that patients have available, the trust that we're able to build with patients, delays in care. And, when we look at population health management, we wanted to make sure that we weren't introducing more inequities by taking the averages of things and creating workflows and implementations around averages. We wanted to make this very individual. Similar to Karen's slides about the national averages, Boston Medical Center also sees worse health outcomes in our Black women and babies. Also, what Karen had mentioned about preeclampsia, it is a pregnancy complication that we see a very quick and sharp rise in blood pressure. It happens prenatally. And interestingly enough, many patients do not know that this also happens postpartum. So sometimes, providers or care practitioners will speak to patients about this during pregnancy, but the postpartum piece can really get easily missed. Here's another slide. This is Boston Medical Center data. We know that our Black patients are experiencing preeclampsia much more often than our white patient population. And when they do, they are at over 2 times higher risk of developing a severe morbidity and mortality outcome. So what we've done, we have really tried hard to create a team-based model for our moms who are at risk for developing hypertension. We really looked at a lot of different companies when we thought about implementing a remote monitoring program. We did a nationwide search for a company that would partner with us and tailor specifically to a prenatal and postpartum population. I'm going to be talking a little bit about both prenatal and postpartum. So I know we're trying to focus on postpartum, but there are some really interesting lessons learned through that I wanted to make sure I included. And so we found a company that offered a particular platform that was very tailored to what we were looking for. The platform also was able to offer us a device, a blood pressure machine that was cellularly enabled. And this was a really critical point in our program development because we did not want to introduce any additional barriers by making any of this work on the patient. And so what happens is we have patients who come into our health system for prenatal care. They receive a blood pressure machine, and that machine is connected to cell towers. It does not require the patient to text us their readings. It does not require the patient to have Wi-Fi at home. It does not require the patient to have a data plan on a cell phone to get the data. The data is automatically picked up by cell towers and pushed through into their medical record for our nursing staff to review. We've created a lot of patient-facing materials in this space too. We have videos in multiple languages. We have handouts, paper handouts that patients get. And I also do a lot of teaching over video and telemedicine with patients at multiple points during their pregnancy and postpartum to make sure that they're engaged in the program, that they understand why they're doing this, why this is important. And we're really seeing some great things come out of that. Our program has 3.5 FTEs. So one of those is for a full-time nurse who monitors the portal. The portal is not built for the nurse to monitor every single data point that comes into the portal. It is to monitor the severely high readings and the severely low readings. And so what we're able to do is really streamline what the nurse is spending her time on and really focusing on those patients who are high yield, who are at risk for readmission, for preeclampsia, for an adverse outcome. The platform that we use also has a text-based service. And so what that we've programmed it to do is if patients have a severe range blood pressure at home, it sends them an automatic text message to their phone that does give the number to our labor and delivery unit, which is monitored 24/7 by our labor and delivery team. And so patients can get connected with care on the hours that I'm not focused looking at that platform all, 24/7. So our preliminary analysis, which it has taken quite some time to get to this point because our ends are small. So over the last 18 months of really delving into this, we know that early and frequent monitoring leads to better diagnosis and just better care in general for our patient population. We've really noticed that over the course of these 18 months, we're seeing a significantly higher population of patients who actually have chronic hypertension and not gestational hypertension like they maybe had in a prior pregnancy, which is really important because both of those conditions are treated so differently in pregnancy with medications and with fetal monitoring. So they mean very different things. So it's really important that if we know a patient has a history of preeclampsia, a history of gestational hypertension, chronic hypertension, any risk factor, and we're able to start getting their blood pressures prior to 20 weeks of pregnancy, we really get to trend that data over, many, many weeks, hopefully months, which gives us a very firm indication of what their true diagnosis is. And, back to something that Karen was talking about, we know that that patients being taught to take their blood pressures at home is a very valid tool and is just as valid as having those patients come into the clinic. So we spend a lot of time educating those patients on how to take their blood pressure correctly at home, what to do if they have readings that are outside of the particular parameters, and it helps us to expedite the right level of care to the patient at the right time, which those two things are so critical when we're talking about outcomes. So here's what I see on a regular day-to-day basis when I'm looking at patients. This first patient was I'm gonna go back there, sorry. That first patient is a pregnant patient who you can see had really normal blood pressures throughout her pregnancy. And you can sort of start to see that little slope of an uptick. And then you can see where all those red dots are, particularly on the diastolic line. And what that was she actually had developed preeclampsia. And so I was able to do outreach to her very quickly. We were able to get her into the hospital, get a full preeclampsia assessment with fetal monitoring, with serial blood pressures, with lab work, both kidney and liver assessments. So we're not looking at just that one particular organ, to give her some really great information about how to manage this pregnancy, to talk about delivery timing with her care providers. She did ultimately get delivered and did have some postpartum concerns, but just an example of how we're able to catch these things very quickly with this type of data. This second patient was a patient who developed postpartum preeclampsia. You can see right where that heart is where she delivered. She went home very quickly at home, developed some extremely severe range blood pressures. She received a call from me within 2 hours, actually, of those blood pressures, and was into the hospital in labor and delivery, receiving magnesium and getting the level of care that she needed exactly at the right time when this was happening. And so when you think about that, we really think about what would have happened if we didn't have this program, if she was just at home not feeling great, or maybe had no symptoms at all and just let these blood pressures that you can see got up to about 180 over 120. And what would have happened if she was just left and many days went by? So this next slide just this is an interesting slide. So when we started this program, our goal was really to provide better patient-centered care. It was not to decrease readmissions. It was not to save money. We wanted to be able to provide better care to the patients who needed it and who were struggling to get into the hospital 3 times a week for all of this fetal monitoring, all of these prenatal visits that we were asking them to make. But incidentally, we did see a decrease in our postpartum hypertension readmissions. One particular piece about our postpartum program is that we also have developed a relationship with our pharmacy team. That pharmacy team helps to expedite any medication titrations for our patients who are living sort of in that mild range of hypertension postpartum. We've developed an algorithm, and if patients meet certain criteria for low to moderate range blood pressures, we're able to up titrate or initiate antihypertensive medications in the postpartum period, which we think is what is affecting this readmission rate, because we're able to catch those mild blood pressures before they're getting to the severe range and before we need patients to come in. We also do have, expectations that these patients are asymptomatic. If we're seeing that they're symptomatic and having these mild range or moderate range blood pressures, we do still have them come in to get their lab work and things like that. But what we're also seeing there is we're potentially avoiding the actual, 2-day, 3-day readmission because they're getting a thorough assessment and potentially getting, again, started on medication earlier. This is just a quick snapshot of who we're monitoring and why they're being monitored. This is prenatally who we're seeing. And on this next slide here, we go a little bit deeper into what this is. So we also use the U.S. Preventative Task Force criteria to figure out who gets enrolled prenatally: chronic hypertension, diabetes, history of preeclampsia, multi-fetal gestation, any kidney or autoimmune diseases, and a new diagnosis of preeclampsia would get a patient enrolled prenatally into the program. And then postpartum, if a patient didn't meet any of that criteria prenatally, they could meet it postpartum, and they also have a second opportunity to get a blood pressure machine for home use at that postpartum time during their delivery and postpartum stay in the hospital. Again, just talking about population health management, one of the things that we were very critical on is to make sure that we weren't introducing any more barriers when we created this program. That's been challenging. There's certain things that we couldn't get around. For example, the approved devices that are that patients can use at home that we know are validated, they actually don't have an XL cuff, a true XL cuff. So for our patients who don't fit either a regular or a slightly larger cuff, we struggle with their monitoring and how to monitor them the same while we don't necessarily receive their data the same. And so that's one thing that we've really battled with. But we're doing a lot more education around preeclampsia. I do so many just touch points with patients that never got any of these touch points before. Incidentally, it's also helped us to pick up other things like patients who are having fluid overload postpartum, patients who have DVTs, because they're getting that 3-day postpartum check-in with me. And so just getting that assessment where they might have waited until 2 weeks or 6 weeks postpartum to talk to anybody in their health system, we're getting that information much quicker. So the next 2 slides are just quick examples of patients. This was a 35-year-old Black woman with preeclampsia in her first pregnancy, developed it again in her second pregnancy. She came to our clinic visit and had high readings for the first time. And by the way, these are true things that truly happened. She had some mistrust in the cuff that she was using at home, and and the cuff that was in the clinic. And so there was just a lot going on. We were able to get her the cuff that we use, the one that we know is validated. And sure enough, she went home. She was still having high readings. And we were able to get her to come back to the hospital. She was hospitalized because her blood pressures actually did take off from there. She actually was then, while she was hospitalized, she had an abruption, but she was in the hospital and abrupted in the hospital because her blood pressure machine at home that we had given her drove her in, and I was able to connect with her, get her in quickly, and who knows what would have happened if this had happened at home. As I mentioned before, we're seeing a lot more chronic hypertension in our population, and so this patient is a 37-year-old Black woman with preeclampsia in her first pregnancy. She developed chronic hypertension in between her first and second pregnancy. She never needed any blood pressure medications. However, her baby wasn't growing as expected. She had an uncomplicated induction and had a baby that was just under 6 pounds. At her postpartum, 3 to 5 days postpartum, she started to have some spikes here. Sorry, I can't get this little screen out of my way to get to the back of this. Okay. And so she was working with me. I was able to get her started on some blood pressure medication. We were able to titrate her. She did go to triage for a visit and have a full workup, but I was able to keep a really close eye on her for that 6 weeks postpartum. And she avoided a readmission, which was great. One of the big things that we're also doing is, so we're monitoring our patients postpartum until about 6 weeks postpartum. Sometimes we keep them a little longer if there's, things that we're seeing, if, a patient has cardiomyopathy or something like that, we keep them a little longer. But we're really also focusing on making sure that these patients have connection with a primary care provider. About 50% of our patients had no primary care provider either listed or that they knew of was as considered their primary care provider. So we're really working hard with our internal medicine team to make sure that our patients are connected, know who to call, know where they're going next after they leave the obstetrics service. I make it in time. Okay, I'm a little bit behind. I'm going to stop sharing now. Okay.
Thank you so much, Megan and Karen. Appreciate you both presenting today. We do have one question that came in from Nydia. Megan, it was for you. What is the platform that you've been using? I love the graphs that they create, and it's cool that you're able to see them from. I assume that you said that's 3.5 FTE, so there's other nurses that have the system in their homes as well, or?
Yeah, so it's actually 1.5 nursing FTEs. We have a patient navigator on the ground in the clinic who's responsible for helping to enroll the prenatal patients and also assist the postpartum unit with any technical difficulties. The platform that we are partnered with is called Rimidi. RIMIDI. I'll put it in the chat. Great tech company. We've worked with them now for about 3.5 years. And those pictures that I showed are their platform. I've trialed a lot of other companies, and there are different ways to display the data that give, a similar pictorial. And so, I think the tech companies are still catching up a little bit in this realm. Like, they approach it with a very pop health management, like internal medicine, GIM, primary care lens. And so, pregnancy and postpartum is different, and we do different things for different people who have different diagnoses. And so they're still catching up on that. And so we've been working closely with Rimidi to do just that, to really make a women's health focused model in the tech space.
Great. And Karen, do you have, I know you said the scale was quite different. I mean, you have 500 approximately, Megan, if I heard you right, for Boston Medical, and then you had like thousands of cups that you were handing out. Do you have ways that they then submit data automatically in your system, or could you describe that, Karen?
Yeah, so these are validated for use in pregnancy, which I think is the most important thing, right? And they have a little QR code on the information that we give them, where they can upload the information directly to this app. So what happens is they're taught to read it, right? So you want to empower the patients to understand their blood pressures. And that was the little bit of limited data I showed you on that study at the end of my presentation. But also you want to know, is it decreasing disparities like you had anticipated? And so one of the things that kind of makes me a little upset is that researchers out of Harvard are actually looking at this. This should really belong to Missouri, let's be honest. But they're looking at outcomes and successes and barriers on the back end with the Preeclampsia Foundation. And that data is not released yet. So, they say once you get one grant, the money just keeps flowing. So our first grant was before the COVID pandemic, and then we applied for COVID funding and were able to secure that. And we just recently got quite a bit of funding for our Perinatal Quality Collaborative. So we're hoping that we can continue this and distribute these cuffs across the country, or across country. Oh God, that would be expensive. Across the state, so that all of our pregnant patients can benefit from this.
So what's the name of the app? Do you mind putting that in the chat?
You can't upload it. It's exclusive to this program. So it's the Preeclampsia Foundation and the Missouri Cuff Kit. So it's exclusive to Missouri.
Okay. At this point.
Yeah.
Okay. All right.
See, I said you want to move here, but I don't, because you'll increase our cost of living.
All right. We have a couple more questions, and also want everyone to take a few minutes to put in the chat if there was one key takeaway or a couple of key takeaways. If you would put that in chat, that would be great. There was a question from one of the participants, from Yvette, who says, who did you contact to initiate this process? So I'm not sure who that's directed to, but I think, Megan, if you start with that, who are your partners to begin with?
For the platform, or for Yvette, do you want to just, I don't know exactly, did you mean the Remedy platform or the program? I think you're muted there.
Hi, it's actually for the program itself, because I'm one of the nurse practitioners that see the patients afterwards, and I am able to offer them the blood pressure cuff, but I would love it to be, it's only the patients that we see with our OB hospitalists. Not all of the patients get this. So some of the nurses know that we do this, so they sometimes will ask me, can I get a blood pressure cuff? Because this doctor isn't going to give them this blood pressure cuff. And I said, oh, absolutely. So I give it to them, but I want to know if we can implement this overall. It would be amazing from what the data that you've shown us today.
Yes. Yeah. So, I think, so our process started stepwise. We started internally with just our 3 clinics. Then we started to grow externally. And what happens is at some point it just gets too big for one person to manage. So, we're sort of at that tipping point where we're getting another nurse. We're starting to figure out how we can spread this to different areas. Because when you start to talk about Karen, like statewide stuff, you really need all of the hospital systems to have their own model of care and how they're going to own it themselves. And so that's where we're at now. We're talking with our community health centers and our community health center partners. Because your patients also want to go to your community health centers. They want to go to their people that they trust. And so we're sort of at that tipping point where we're trying to find a balance between taking it on as like the hospital itself and sharing the responsibility with the CHCs. So we're sort of in that like stuck moment.
So what would be the first step you would recommend? If I work with OB hospitalist group, who would be my first contact?
I would start with your chair and talk about, how you approach care and how you can make it patient-centered, and how, technology is just an area that we have got to move forward in. Like healthcare has got to catch up and to be in this space. We're working right now with some of our mass health partners to even get all of this work reimbursed. So if you can find a way to offset some cost, I think that sometimes helps with the thoughts of like where you can create revenue and, things like that. So ours is still grant funded, but at some point we're really hoping that it's self-sufficient in the sense that it's just net neutral, with decrease in readmissions, with my billing of my telehealth, with, where you're redistributing the work. Like, I'm sure that your practice has like nurse visits for blood pressures. We don't need to do that anymore. All of our patients who need them have blood pressure machines at home. So we do telehealth instead. So you save on that side and you can shift the work to different places.
Yeah, and we're right at 1
Thank
o'clock. Thank you so much, Yvette, for your question. One quick question, Megan, is whether the blood pressure cuff is integrated into your EMR system, and just yes, no, I guess. So
it is, it's clunky. EMRs were built to not let anybody in. They're very private spaces. So to get other tech companies, things to integrate, it's hard. But we've found ways to work around it.
Great. Thank you so much, everyone, for your comments. If you still have a minute and we're willing to type in any 1 or 2 key takeaways before you sign off, that would be much appreciated. And Karen and Megan, if you just hang on for a minute, we'll, as we let everybody sign off, and then we'll just stay in this space. But thanks again, everyone, for coming today. We appreciate our speakers. They were amazing. A round of applause for you all, virtual round of applause. Thank you, thank you. And you can see people are putting in chat some of the things that, some of their takeaways. So, all right, have a great day, everyone, as you go back into the field doing your work. And again, Karen and Megan, if you just hang on for a minute. So thank you. Bye, everyone.